How many of you think you have your executives convinced that flow delays in the emergency department are a patient safety problem? Good. So about a third. How many of you feel like your senior leaders are on board with improving flow in your hospitals? A little bit more than that, about half. So that's good. So part of the goal of this talk is to give you some information, some data that you can use with your senior leaders, with other people that you talk about to say, you know, this isn't just an inconvenience. We're not just complaining about these delays down in the emergency department because we want to complain. We really do have serious patient safety concerns, and here are some of the data that show what's happening with delays in the emergency department. So I want to take us through just a little bit about the Institute of Medicine reports on calling to end boarding and diversion in emergency departments, talk about data from a variety of different sources on the consequences of crowding and delays in care, and I think talking about the consequences of delays makes more sense because it fits with that patient flow paradigm very nicely than necessarily talking about the consequences of crowding. And then finally, what are some breakthrough strategies to try to improve flow? There are other talks that are going to dwell more on that than this one, okay? So what about the Institute of Medicine? 2006, June 14th, 3 reports released, one on pre-hospital care, one on pediatric emergency care, and this one, hospital-based emergency care at the breaking point. This particular report called for the ending of boarding and diversion on June 14, 2006. I don't know about you, but it didn't end where we're at completely, just because these Institute of Medicine reports were published. Not uncommon. But if you want to summarize in one slide what the Institute of Medicine report said and why we're where we're at, between June 1993 and 2003, visits to emergency department grew by 26% to then over 114 million annually. At the same time, we lost over 400 emergency departments across the United States, and almost, and this is the key, almost 200,000 inpatient beds were taken out of service, so they were no longer operational in hospitals around the country. So you put that together, and you got to say something's wrong with this picture. Something just isn't quite right with the picture that we're facing in our emergency departments. This is old, but I just love the way that they put these movies together. This doesn't fit. We're going to have a problem with 200,000 fewer beds. You have sicker people, more people going to fewer emergency departments with fewer places to put them. So what did they call for? Hospitals should adopt operations management strategies that have been proven in many other industries to reduce variability in flow, to reduce delays, to improve the system dynamics of your hospital, including informatics around real-time operations information. We talked about the limitations of electronic health record for real-time clinical data yesterday, and they certainly are. We're in this awkward transition phase between paper and electronic. But a lot of times, and one of my biggest disappointments about electronic health records and these enterprise-wide systems is that they're not addressing real-time operations management data with real-time flow metrics, et cetera. Some are, but most of the systems aren't addressing that. Most of them are focusing on clinical data, and it takes some champions in hospitals to get the real-time flow metrics up and running at the same time. CEOs need to lead the effort. If your CEO isn't interested in improving flow, then your senior vice presidents aren't going to be interested in improving flow, and then your directors aren't going to be interested. So it really needs to come from the top if it's going to be a successful strategy, and it's going to become one of the top priorities for your hospital. And that was one of the exact recommendations that the Institute of Medicine called for. And then ending boarding and diversion, as I mentioned. Now, they didn't say that this can happen in a vacuum. There needed to be changes that would give hospitals the tools to do so, also some incentives to do so, sort of a carrot and a stick approach. We're obviously still managing and dealing with it, but that's what we're here to talk about today. And why? Why would you end boarding and diversion? Well, what do people care about? What are outcomes that people care about? I mean, I care if I'm going to live or die when I come to the hospital, all right? I want to be helped by the care you're providing if I come to the hospital, so my quality outcomes are important. And then people care about money, the 3 M's, all right? Mortality, morbidity, and money. So I'm going to focus on the first two, and I'll explain why I won't spend a lot of time on the third, because there have been several economic studies talking about the cost, the opportunity costs, et cetera, of crowding. But I'll get to that in a minute. as to why I think the business case for this is what we talked about yesterday, the business case for patient flow, all right? But we'll focus a little bit on mortality and morbidity. Some of you may be very familiar with these papers, and if you are, feel free to chime in. But if you're not, this is a nice quick little list of useful resources to have to give to people and say, you know, this isn't just about us having a bad day downstairs, all right? 2 studies from Australia, and these were published several years ago looking at the association between crowding, as they defined it with a couple of different definitions that we'll get into, and patient mortality. Now these are just associations. You can't say that that's a causal link, but they're associations, all right? The first one is by Spravoulis and colleagues from 2006, and they looked at Western Australia emergency departments, and they saw that overcrowding was associated with 2, 7, and 30-day mortality, all right? And the key graphs are here, and they looked at it from 2 different perspectives. The one on the left said if the hospital is less than 90% occupied, that's the survival curve that's on top. If it's 90 to 99% occupied, that's the survival curve in the middle. If it's over 100% occupied, that's the survival curve on the bottom, and those differences were significant. They also looked at very similar type of thing. The corollary of the hospital being over 100% occupied is that those patients are sitting in the emergency department. That's the access block that we talked about yesterday. A common definition in Australia is spending more than 8 hours in the emergency department. So this is less than 10% of the ED occupied by boarders is the top line. 10 to 19% is the middle line, and 20% or above is the bottom line as far as the percentage of your emergency department treatment spaces that are occupied by people that are waiting to get a hospital bed. Again, associations with mortality. This is alive or dead. Okay? Hard outcome. Drew Richardson and his colleagues, same year, actually I think the same issue, looked at it, again, associations between crowding and mortality. Defined it a little bit differently, looking at the total occupancy of the emergency department. And they simply compared those time periods of the top quartile of emergency department occupancy with the bottom quartile of emergency department occupancy. And the 10-day mortality was higher in patients who came into the emergency department during those top quartiles of ED occupancy, with a relative risk of 1.3 as far as, and these are people who are admitted, people having association with mortality. So those are a couple of the mortality studies. There are not as many in the United States looking strictly at the emergency department, but these are 2 important papers. These ones you really got to know. The top one in particular. How many of you board ICU patients for prolonged periods? Okay, so there are about 10 or a dozen hands or so. This Chalfin paper, have any of you seen the Chalfin paper? Okay, this is a really important study. It was a secondary data analysis looking at patients who were admitted from intensive care units across the United States. And it's looking at the impact of delayed transfer of critically ill patients from the emergency department to the ICU. And what they did, this is the impact database, over 200,000 patients from 2000 to 2003, 120 intensive care units, 90 hospitals, and they looked at ICU mortality, in-hospital mortality, okay? And the exposure in this, the delayed group, was spending greater than 6 hours in the emergency department after the decision to admit to the ICU. So they looked at all the people admitted to ICUs, and they compared that group that had that delay in the emergency department compared to others, and this is what they found. 50,000 patients, only 1,000 had this delayed transfer, okay? Exposure greater than 6 hours, as I mentioned. They had similar Apache scores, similar risk, etc. But the ICU patients with the greater than 6 hour delay had higher ICU and hospital mortality, as well as longer inpatient length of stay. And it's underlined for a reason. I mean, that's important. Higher mortality, hospital and inpatient, plus longer inpatient length of stay. And it's probably one of the strongest papers we have in the United States looking at mortality as an associated risk associated with crowding. Brendan Carr and others from University of Pennsylvania, Penn has done just a great deal of work looking at different quality outcomes associated with delays in care. They looked at blunt trauma patients who were intubated in the emergency department and looked at the association between delays in the emergency department and ventilator-associated pneumonia. It's a very high-risk condition. Ventilator-associated pneumonia has a high mortality rate. And they found that for every hour increase in the emergency department, length of stay after being intubated, there was a 20% increased risk of ventilator-associated pneumonia. And if you think about it, there's a number of different interventions, ventilator bundles that have been implemented in intensive care units to prevent ventilator-associated pneumonia, including angling the head of the bed, all the different things that go into the ventilator-associated pneumonia pathway. There's reflux prophylaxis and sedation weans and all that type of stuff that probably doesn't happen in most emergency departments. Okay? So that's another key paper. So that's really looking at mortality and crowding. What about morbidity and the quality of care that we're delivering in our emergency departments? Fishman and others looked at acute coronary syndrome patients or patients with potential ACS, all right? And they looked at patients who came in while there was a trauma team activation going on and looked at how well the care and the outcomes and the complication rates from the patients who presented during time periods when there was a trauma team activated versus time periods when there wasn't. And there was higher 30-day cardiovascular complications in the group. Again, looking at what environment are our patients walking into. Because we all know that there are times where we're going to be on top of a potentially critically ill patient or a seriously ill patient. Acute coronary syndrome I wouldn't probably put necessarily in the critically ill category. Most of us wouldn't. That's the point. If there's some other things going on in the emergency department when they come in, how well are we going to deliver the best care and guideline-based care for those patients? This is a little bit old because it's a lytic study from Canada. And I think most of us are doing primary angioplasty now for acute MIs. But they looked at system ambulance diversion. They had 3 different levels of network crowding that they used ambulance diversion status as their measure of network crowding, from none to moderate and high. And they had longer door to needle times during those time periods when they had high network ambulance diversion compared to low. All right? Eula Wan and colleagues, she's at Mount Sinai in New York. She's done a lot of work on pain and treatment of pain for patients who present, particularly elderly patients who present with hip fractures, etc. This is not going to surprise us. This is not the only study looking at analgesia. But if one of our goals is to really be patient-centered and treat their pain and treat it in a timely fashion, it's pretty hard to do when your nurse is taking care of several boarders at the time, the ratios are all blowing up, and the delays to even get back can be seen depending on if some of those strategies we talked about yesterday haven't been implemented. Obviously, we're not going to treat pain as timely as we could. So fewer patients received pain meds during high census, and it was longer time to pain assessment, longer time to ordering, and longer time to administration. All of these. This is back in 2008 in academic emergency medicine. What about the core measures in community-acquired pneumonia? 2 different papers from Annals of Emergency Medicine. Now, we may have a wide range of opinions about the core measures and what they're asking us to do for community-acquired pneumonia, but the ability to get antibiotics into the patients who have presumed community-acquired pneumonia within the time periods that have been suggested was impaired when a couple of different measures that Jesse Pines has used at Penn. He has several different metrics, kind of a group of metrics he uses that identify crowded periods, looking at the waiting room number, the total number of patients in the emergency department, and then he also does some metrics that combine acuity and borders with the emergency department at the time of presentation. Again, I think that's one of the most important things is, what does the ED look like when people walk through the door? Because those are the patients that are going to be most at risk for the delays in care affecting their outcomes. Likewise, the same issue, antibiotic treatment delays, looking at, they use the measures of higher ED volume and the complexity of patients. All right. Acute coronary syndrome treatment. I mentioned this is a similar study that was done looking at 30-day mortality or 30-day outcomes with patients with presumed acute coronary syndrome. This looked at how well did the overall care comply with American College of Cardiology guidelines. And I like the editorial title, the Emergency Department Crowding Paradox. The longer you stay, the less care you get. That's Judd Hollander and Jesse Pines, again, looking at how the environment that these people are coming in affects the care that they got. We tried to wrap all of this up. Steve Bernstein, we were on a task force together, Society for Academic Emergency Medicine, looking at crowding and really trying to understand what are the effects of it on education, which is a unique goal for academics, as well as patient outcomes. In this article, already there's more papers that have come out, of course, since then, but it really kind of ties together all the different papers looking at morbidity, mortality, and some economic outcomes as well. So that's mortality, that's morbidity. What about money? There are a couple different studies that look at the opportunity costs to the hospital, and Rick mentioned some about it yesterday, about what the cost to the hospital is from a revenue standpoint, or the opportunity cost for ambulance diversion. You certainly can and should know the numbers, as Rick mentioned yesterday. But I think the takeaway from his talk was to look at what the revenue opportunities are for really making your emergency department work. And so I would suggest that the business case for improving patient flow is likely going to be your strongest driver for affecting operations at your hospital. And I think that's going to be a more powerful case than some of the, especially the economic studies associated with the crowding literature, because they're kind of mixed back and forth, because all the data analysis from the revenue and expense perspective in the economics literature and the studies that have been done in annals, it's really tough to pull it all together and make this really clean case about what boarding does and what the cost of boarding is, because it all depends on your perspective. You know, which president was that said, what I really want is a one-handed economist, because economists always say on one hand, but on the other hand. And you're going to get into that back and forth of whose perspective are you looking at when you really are looking at the cost and the economics of boarding patients in the emergency department. So I would turn that on its head, not worry so much about trying to get all the money and dollars worked out with boarding, and instead focus on the opportunities for improving patient flow when you're looking at economic outcomes. That said, the papers we just went through are really important as far as putting the whole picture together for people and saying, you know, it's not just about money. There's other things that are going on here that we're very concerned about. So bringing back to this report, what are some high-impact strategies, some big picture strategies from a hospital perspective? There'll be other talks that go into this in more depth, so I'm not going to spend a long time on it. But in April 2008, ACEP Task Force on Boarding published a high-impact strategies book, paper about improving flow across the hospital. And that's available on the website. You can get that from ACEP, and it's in your handout. 3 strategies that, from across the system perspective, that I think could be helpful. How many of you seen Peter Vecellio's full capacity protocol work at Stony Brook, or heard of it? This is basically the Adopt a Boarder plan, and he actually has some recent publications about it, so that's great. Got it out there in the literature as well. He's been speaking about it for years, and essentially they've developed a plan whereby boarders from the emergency department, when they reach certain saturation points, go to inpatient units. And they board in the hallways of inpatient units rather than boarding in the emergency department. Basically says, if you have this many boarders, why keep them all in one place? Right in your front entryway. Why not move them to different units and distribute the workload? And actually it's been very successful, and it's allowed them to stay off ambulance diversion. And he talks, it's beautiful, talks about the magic elevator effect of there are no beds, there are no beds, there are no beds, and then somehow between, we're activating the full capacity protocol and the patient's in the elevator. About a third of the patients, the bed appears somewhere between the first floor and whatever floor the patient is going to. About another third, and you need to look at the paper to get the exact percentages, but about another third get into an inpatient bed within an hour on the inpatient units. And so it's a relatively small percentage that board longer than just an hour on the inpatient units, as opposed to how long they spend in the emergency department. So that's certainly one strategy There's probably like 7 deadly sins of why you can't do that. The first is, it violates fire code. Okay, so you have to talk to your fire marshal. Well, it's the Department of Health won't allow it. There's a whole long list of things that are always going to be mentioned about why you can't do that. Most of those are myths. Joint Commission won't allow it. That's a myth. Okay? So you can do it. You have to be selective as to what patients you would do that with. You can't put an ICU patient on a ventilator in the hallway, but sometimes they're on ventilators in hallways in our emergency departments, but they don't use this for all patients, but certainly it's been a good strategy. Elective surgical smoothing. How many of you have heard it all about how the way the operating rooms are scheduled affects what happens to us in the emergency department? Eugene Litvak is an operations management professor, was at Boston University, he now has his own consulting company. He's still affiliated with Harvard and BU in Boston. He's done a lot of work with IHI and others. And he's really shown that it's easier to predict the number and type of admissions that hospitals are going to get from us, from their emergency departments, than it is to predict the number and type of admissions they're going to get from the elective schedule that they control in their operating room. You just mentioned Todd talk about, but I want a 4-hour block. There he is. 4-hour block in the operating room. The problem is when you give that 4-hour block, it can lead to widely different demands for inpatient beds, particularly when you're talking about surgeries that are going to need ICU care, et cetera. And what Eugene Litvak has shown is that the variability from the schedule, which he calls artificial variation in demand, causes much greater delays and problems with hospital capacity, greater delays for us, and greater fluctuation in the demand for inpatient beds than the natural variation of demand that we have. Yes, we don't know the exact number today, but we know we're going to have in our emergency department about 40 admissions today. I mean, that's about the right number. And so this is a very interesting area to look at. You can actually go on Eugene's website, and there's a number of different papers looking at natural versus artificial variability in demand. He actually had a Center for Variability, or Center for Demand Management in Healthcare that he runs or a website. And so there's some interesting concepts there. If you're going to tackle that one, you got to have some big champions from your surgical colleagues, and you got to have senior leaders involved. But and it's probably not going to apply in every one of your emergency departments, but it certainly does drive demand in hospitals that have high occupancy rates and a very heavy surgical volume. Earlier inpatient discharges, how many of you have tried this? From the inpatient units? Okay, I think every hospital struggles with this. And the only thing I'll mention about it, a couple things. One is that a lot of places start out with the idea that we're going to get everybody out at 11 or everybody out at 10. You know, pick a specific time and we're going to get all these inpatients discharged at that time. Well, it's not like a hotel. And whenever you batch workload, you're going to create bottlenecks. And so the strategy that everybody's going to be out at this certain time really violates what we were just talking about. That's not smoothing out your workload, okay? That doesn't mean that trying to get people discharged from inpatient units earlier isn't a good strategy. I think it is. It's just that you can't group it all at one time. And if you really look at all the different things, and I'm going to go into this lean talk here later this afternoon, inpatient discharge is a great lean project. Because if you really need to sit down and map out all the different things that need to happen for that patient to actually leave your hospital building. And but it can have a significant effect on how long we have to board patients in the emergency department. Okay? So I've said there's lots of different things that we can do in our emergency department to improve flow. When it comes to boarding, you have to have a hospital-wide strategy. And it doesn't necessarily mean that you're the ones that have to go out and run the inpatient discharge projects, okay? Because that's taken on an awful lot. But getting your senior leaders and your colleagues and others invested in these types of hospital-wide strategies, I think that is our job. Okay? It may not be our job to do all this work, But I think it is our job to convince our colleagues, our senior leaders, and others why they need to do that and why it would help the hospital. There's a strong business case behind these, and it can reduce a lot of the patient harm that occurs from the delays that they experience in our departments. And I think it is our job to be the champions to say, you know what, that's not acceptable. We can do better than that. So those are a couple of the high impact strategies, or the three key ones. Really the ultimate goal is to have a system-wide view of patient flow with clear lines of responsibility and accountability. And as I mentioned earlier, you got to ask the question, is the CEO involved? Is the CEO on board? Because if he or she isn't, it's really difficult to get people energized about adopting hospital-wide strategies. Hospital with a disengaged CEO reminds me of this little thought. When I die, I want to go peacefully in my sleep, just like my grandfather did. Not screaming like the passengers in his car, okay? So that's kind of where you're at. If you're in a hospital and you're in the emergency department, you're kind of like the screaming passengers going, wait a second here. Grandpa, wake up. You got to have the CEO who's engaged and says, you know what? Patient flow makes sense from a quality standpoint, from a satisfaction standpoint, from a business standpoint, from a staff satisfaction standpoint. You know, almost all of us have these balanced scorecards. You know, if you look at the strategic plan of your organization, there's going to be a quality goal. There's going to be a business goal. There's going to be a satisfaction goal. There's going to be a people goal, a human resource staff satisfaction goal, okay, or a growth goal, all right? Pillars, strategic direction, balanced scorecard, whatever you call them, they all are kind of those 4 or 5 categories in everybody's organization. It hits every single one of them. And it's an opportunity to improve across that entire spectrum, so it makes sense from that standpoint. It's about ownership in a lot of ways. Larry Summers quote is saying, in the history of the world, no one has ever washed a rented car. Okay? So unless you really own the operations and your colleagues across the whole institution own patient flow as a key priority for the institution, it's going to be very difficult to make progress. All right? We can own the front end of the emergency department, and we need to, and we should. Okay? And there's many things that we can do. But when it comes to that transition from our departments into our institution, we need a lot of other people to be owning the issue along with us, because it can't be solved from the emergency department. The biggest mistake, and I'm part of it, the biggest mistake of all this delay was the name we chose for the problem we're facing. Emergency department crowding. You know, what a mistake. Because if you don't know anything about emergency department crowding, if you had never heard of that phrase, what is the first thing you would think when you say the problem of emergency department crowding? What's the problem with the emergency department? That's the logical question. All right? We can't blame people for the logical thought process that would happen if you didn't know anything about what's really driving it, and you heard about this terrible problem called emergency department crowding. What's the natural thing? They're all going to say, well, it must be all those people with colds and really minor complaints rushing to go to the emergency department. Okay? And so that really has plagued us throughout this whole discussion about how to motivate and get our system leaders, our hospital leaders, and our other colleagues engaged in improving patient flow. From a take-home perspective, a growing body of evidence suggests that, yes, delays in care are more than just an inconvenience. They're going to do more than just affect our patient satisfaction scores. They're going to do more than just suck the life out of us while we're working during our shifts, okay? They actually have been shown to be associated with mortality, alive or dead. A much bigger body of evidence around associations with quality of care that we do not think is exemplary. Okay? Delays in pain treatment. Less effective use of guideline-associated care for acute coronary syndrome. Less ability to meet core measures for community-acquired pneumonia. Delays in treatment for hip fracture. There's a long list of how it's not meeting our quality goals. And then from a money perspective, the broader discussion we talked about yesterday about the business case for patient flow. It's not just an inconvenience, it harms patients. So what about next week? I would say convincing, as I said. The good news is about a third to just under half of you already feel like, you know what, my senior leaders believe that patient flow is an imperative for improvement at my hospital. And that's great. And if you weren't able to raise your hand, I would make that a goal for 2010. So that a year from now, you could say, you know, we've really made progress at getting key people motivated about reducing delays in care. And some of that's got to be senior leaders. Somebody's got to get to the CEO. All right? Because if you can get the CEO, then it's all downhill from there as far as starting to see changes at your hospital. It's tempting because you know a director better to just focus on the director that you know. But he or she isn't going to be able to drive this if the C-suite doesn't think it's important. All right? So you got to keep working until the C-suite is engaged as well. Consider partnering with your inpatient leaders. You're not going to be able to drive changing the OR schedule by yourself from the emergency department. That isn't going to happen. That's a recipe for disaster. But if you got champions and you looked at these data, they're very compelling. The good news is, if you adopt Eugene Litvak's approach to smoothing the OR schedule, which means you got to give up some of the blocks, which is heresy, they can do more surgery. There's better availability of operating rooms, okay? So one of those strategies would be really important. And it's not just about the ED, it's about quality of care issues and other drivers. Again, that whole balanced scorecard, you have the ability to ring the bell on each of those areas by adopting some of these techniques. So I'm going to wrap up there, get us back on time. But does anybody have any quick comments or questions about these? Yes?